The next speaker is Grace Terrell, who's president and CEO of Cornerstone Health and a primary care physician. And she's going to take us back a bit to narrative-based medicine. She's going to tell us the tale of two patients. I think in the evidence-based medicine world, it's nice to have people tell us stories about patients because I do think they're very enriching.
I don't need it. So we've heard from a Harvard professor, a medical professor from University of Indiana. We've heard from the JAMA editor, an LMD from the upper state of Virginia. They always think they're superior to North Carolina. And soon we're going to be hearing from the Cook County physician who's in charge of public health here. So I can't compete with that, but I'll do what we do best in North Carolina. I want to start off with a story. And the way I'm going to start this off is to pretend like I'm the professor and pimp some of you folks out there a little bit, because we all learned from the dysfunctional education we had before. And can any of you tell me what is different before you ever see a male versus a female in the room when you just look for a new patient at the name that you can tell about women that you can't tell about men? Some smart folks out there. What's that? No, I'm thinking I'm much more simple than that. But the only people that ever raise their hand, by the way, are the women in the audience because they're at least a little brave. The answer is with men, you can't really tell what age they are because they all have the same names. It's Bob or Jim or Bill or Tom, and they may be 18 or they may be 85. But they are, more often than not, you can't tell. Everybody just names their boys the same thing no matter what generation. That's not true for women. Names go in and out of fashion much more likely. So I'm 51 years old. My name is Grace. I hated it growing up. Your daughter's name is Gracie. I would be very popular now, but I wasn't back then because everybody in my generation had names like Lisa and Kathy and Sharon and Donna, and I was so jealous I didn't have one of those names. I did not realize that my mother was an innovator, and that because right after that came the Grace, Hope, Faith, and Charities. It all went away with Sonny and Cher when they had Chastity. The hippies came along after that, and they started having the Autumns and the Ferns and the Dawns. You remember those? I did not realize that my generation did it either until my oldest daughter went off to first grade. She went to a public school where there's 39 languages spoken, but it's still the South, and so mostly it was African American and white, despite all the 39 languages. And she came home, and and she said, "Mommy, there's a difference between black girls and white girls." I said, "Oh, God, okay, I got to get this right, What's she going to say?" And she says, "All the white girls in their name with an E sound. That's Katie and Callie and Sally, and the black girls have cool names like Fatima. And they all end theirs with an A." I said, "If that's the only change, that's the only difference, progress has been made." I didn't realize that when I named my younger daughter Robin that I was still doing that. If we're hiring those kids now, and you can't tell the gender. They're Taylors and they're Tylers and they're Jadens and they're Jordans and they're Robins. I mean, what's up with that? But what I learned, what you may realize, is this has always been the case. So when I was thinking about this recently, look what happened for those a little older than us. They went through the spring months of the year. There were the Aprils, the Mays, and the Junes. And the ones a little older than that were all about jewelry. So I have jewels. I have opals and pearls and rubies. Any of you all take care of them? Well, the two patients I want to talk to you about tonight are the flowers, because they're the ones that are dying right now. And I have some roses, and I have some irises, and I have some hyacinths, a couple of daisies. And they're the generation of women that is in their 80s and 90s. So I am a general internist, and I see patients in the clinic when I'm not doing my super cool CEO stuff and the other stuff that I do. And this winter we had the norovirus go through our community, and both of these women came in. And the first one was Rose, and she is the patient that you all want to be if you live to be 89 years old. Her husband died a few years ago, but her mind is sharp. She's thin, she drives, she lives alone. She's got a wonderful 2 sons, and she's on one pill. I'm always afraid I'm going to kill her. I just tell her to lick it every day. And she was doing really well. until the end of that norovirus season. I saw her beforehand and patted her on the back. She came back after Christmas, a different woman. The two sons brought her in. She was in a wheelchair with oxygen in her nose, with a hip fracture, with some bruises on her face, some decubitus ulcers, on 20 medicines. And guess what had happened to her? She had interacted with our healthcare system. She had gotten some of the GI symptoms that came from the norovirus, and she went and did what everybody does. She called the beauty parlor, and they told her to go to the emergency room. So she went to the emergency room, and in the emergency room where she was dry, they did a bunch of tests, did a bunch of scans, gave her too much fluid, put her in pulmonary edema, decided because she was old they were admitted to the hospital, where as a result of all the wonderful care that she got from physicians that are my partners in an institution that is exceptionally good, that I also have privileges at, she stayed for a combination of 7 days, got discharged to a skilled nursing facility where she fell and broke her hip and ended up back in the nursing home before she finally got back to my office for her episodic care. Now, one of her sons is a neonatology nurse at another facility in our area, and the other son is married to an RN. So this is a pretty sophisticated healthcare family. And Rose's family said, how in the world are we going to cope with this? Well, the first thing I did is take her off 19 of the 20 pills, but we almost lost her. And we almost lost her because of what everybody did within our current healthcare system, which was probably the very best job that they could with the information that they had in the world that they're in. Well, the second lady, Iris, came in around the same time. And with the same type of illness. I wasn't sure. I was working on a Saturday. We have electronic medical records throughout our integrated medical group, and she came in with two sons, actually. This is really true. She had the same symptoms, but she came to our office rather than the emergency room. We were able to do a few tests there. We were able to give her infusion there while I sat there with her, instructed her sons who were going to be with her that night. I was worried. The lab came back a little dry. She came back in the next day, gave her a little bit more fluid. And then when I went back to my other administrative hat job, the team of people I have in my office took care of her over the next few days and followed up with her. And she's done great. You know what? We all made money on Rose. And we didn't make a whole lot of money on Iris, did we? And that's really what the healthcare delivery system change is about. So we have a system that we want to fix, but we have a system that has rewarded the wrong things. I've been investigating Rose's bill. I think it was over $200,000. When you look at what my company made, what the hospital made, what the nursing home made, certainly what the pharmaceutical industry made, all the things that we've done for her, the physical therapy. As far as I can tell, the bill for Iris was less than $1,000, at least what we billed her. But the infrastructure in place has been quite expensive, and it's been quite transformative. My organization is a group of very average doctors in High Point, North Carolina, that have now spread throughout the Piedmont Triad area of North Carolina. We're an independent multi-specialty practice of average doctors that are on staff at 15 hospitals that are part of 8 health systems. And about 3 years ago or so, we decided that as successful as we've been in the fee-for-service world that we've been in, that it was unsustainable, and if we just kept doing what we were doing, and we've been very successful, we've killed it just like everybody else had, that our future would not be a good one. We think because of the consolidation in our market, that we would have probably been either split apart by the local consolidating hospital health systems, or a trophy on one of them's shelf that can then be used for a market share play among the others. So we decided that if that was our default future, we weren't going to accept it. So we basically have leveraged our future. A group of 180 physician owners and a group of 360 providers has borrowed $25 million. And we've decided that we're going to change everything. We've signed personal guarantees, and we're going to change the way we're going to practice medicine, and we're going to change everything we do. Like Jim Lovell said in the movie Apollo 13, it's not going to be a miracle. We just went there. And here's where we went. We decided we had to do several things to make the transition and make it right. We had to invest in things we hadn't done before, like patient care advocates and folks to help us, like pharmacists to do chronic disease management, all sorts of teams of individuals. We had to be open 7 days a week. We had to have facilities that were different. We had to invest in information infrastructure that we didn't have before, and we've done a lot of that with lots of interesting ways to do things. We had to also change the way we were paid as fast as possible so we didn't go bankrupt. So I can say as of last month, 100% of Cornerstone Healthcare's contracts with every commercial payer through the Medicare Shared Savings Program, through Medicare Advantage, is now in a value-based contract. Because we have to be paid in a way that we can transition and see more patients that are being treated like Iris and less like Rose. So what are we doing with it? It's about the patient. We're changing every single way that we're practicing medicine. So our cardiologists, who have been the cath jockeys of the universe like all of yours have been, are redesigning what they're doing. We have a congestive heart function, not heart failure clinic, where we're taking our sickest class 4 heart patients throughout our organization and doing team-based care to keep them out of the hospital. Our first patient, which sounded like it could have been one of yours, was somebody that had been in the hospital 15 times the first 6 months of 2012. When we put him in this clinic, he has not been in there yet. He's been out of the hospital and is thriving and surviving. In oncology, we've embedded an internist as well as palliative care and team-based care, because when people get cancer, okay, they often end up with readmission for non-cancer things to the hospital, and they lose their relationship with primary care because nobody wants to touch them because they have cancer. So we've put an internist in our cancer practice. We've taken primary care and exploded it and turned it apart. So we got a lot of LMDs. Okay, but we're doing different things. We have 2 that are doing polychronic work, where we're paying them very, very good money to see less patients than they ever did before. And they're taking care of our sickest 20% of our population, at least in our major service area. They have a team of people around them, and they're working on all these issues related to those patients who have 5 or 6 different diseases. My partner, who's one of them, Dr. Richard Orr, who is one of the folks who used to see 30 to 40 patients a day, including his nursing home, hospital practice, and office, now sees 12 on a good day, with the psychologist, with the pharmacist, with the care team that's embedded in there. And he says, this is the way I've wanted to practice my whole life. Dr. Cabeza, who is doing this with a Hispanic population that we have in another part of our community, as well as others, is working with Rite Aid, who has health coaches in the pharmacy to do a lot of the change management. We have extensivists working with our top 1% of our population. We are changing everything. We're changing it very rapidly, because if we have more irises and less roses, we actually probably have a way of enjoying the practice of medicine, doing what we professionally are supposed to be doing for all of our patients, and doing it in a way that's going to be good for America, good for us, but most importantly, good for our patients. So it's not a miracle. We are very average doctors in High Point, North Carolina. We've just decided to go there.